Welcome to a Cisco meeting. You are entering the meeting now. This meeting is being recorded. You are the only participant.
Testing, testing. 1, 2, 3. Testing, testing. 1, 2, 3.
too. Really? Hey,
Hello.
just running around like a chicken with my head cut off this morning.
You're a resident. You're going to do that for 3 years,
Yeah,
right?
that's my job, right? There normally is a little chair there, and I don't know about it.
I'm just gonna like stick this somewhere that I can perfect. I just have it. It might start choking.
In today, all the junk I have. Do you know for this event code, so the Julian calendar is actually 017 on the list. Is it fine that it's just 5? Like, is this the true one? Because I don't want to project.
I don't know.
Okay. Do you know? Maybe?
I don't
mean,
know. She might.
it's probably just 17. I'll just keep it like that. Hello.
Is can I clarify what there's
On the desktop.
Do you know if the event code has to have a 0 in front of the 1? I would think it should have the 0, but it's straight.
Ever since it switched to 2020, they have the 0 in front of it, and a couple of different sessions, they've just not.
Yeah, these are printed out prior to me getting them, so.
Okay, I just wondered about, whether or not it needs to be 6, because it has been historically. I'll just put the 0 in.
Okay, Jan from Grand Rounds, who runs it, says no. It's 17020. So.
Awesome.
All right, perfect.
Thank you so much for asking.
Then when you're ready, you're just going to connect in, right? Oh, there you go. Never mind.
Yes.
Just let you do your magic.
I never remember how to do the lights. Do you know how to do the lights? So normally we turn the cornea up and then you turn the light down right in the center. That's good. Yeah.
Hello. Good morning. Welcome to Dermatology Grand Rounds. Welcome to all of our dermatology residency applicants. This is exciting to have you here. You're getting to see a Utah snowstorm this morning, and we're really glad to have all of you here with us today. We're going to get things started this morning. I just wanted to read, for those of you watching from home who were safe and not on the roads in this snowstorm, hi to all of you. The code this morning for your CME, in case you haven't been able to see it, is 17020. That is this morning's event code, 17020. And without further ado, I am going to introduce Margaret Cox, who is going to be doing our case of the week.
Hi, good morning. Welcome, applicants. I hope you had a nice time at our social yesterday evening. It was a real pleasure meeting you, and I hope for those interviewing today, you have a positive experience. Good luck. Don't stress too much. You're all awesome, and you're almost done. So that's wonderful, wonderful news. And you may be the lucky one standing in my shoes next year, giving this case of the week or something similar. Usually we give a case of the week the weekend before we're on call. So I am the lucky one taking MLK call this weekend. So if you have any emergency rashes, you'll see my face coming into your hospital room. And hopefully that won't happen. Maybe you'll be able to diagnose yourselves and you won't need me. So this morning I will be presenting a case that I saw on my pediatric rotation at Primary Children's with Dr. Luke Johnson. I'm not sure if he's here right now, but, he's doing same-day clinic, so he may not be here, but we saw this cool case during one of our, there he is! Woo! Excellent. Okay, so the chief complaint that we received from the admitting team were that they saw bumps on the left and right hands. This was a 1-day-old baby boy who was full term. He was born at 38 weeks, 4 days to a 31-year-old mom via spontaneous vaginal delivery. He had great APGAR scores of 8 and 9, so everything was fine and dandy until they transferred him to the inpatient maternity ward, and the team there noticed that the babe had a pustular rash. He had several yellow-white pustules on the left hand, right hand, ankle, elbow, and suprapubic region. Mom did not think that these were particularly painful or itchy. The baby was doing really well. He was behaving as a baby does, so basically sleeping and eating. And the original assessment encompassed all the lesions that were observed, so he didn't develop any new lesions during the admission. And otherwise, he was doing well, no fevers. Mom had received regular prenatal care and was otherwise healthy. There had been no recent history of infection. Notably, the baby's mom was Chinese and the father was Caucasian. So on physical exam, we saw a well-appearing newborn who was sleeping. We did observe that there were several scattered yellow to white pustules that were rather flaccid. They measured about 1 to 3 millimeters, and there were several on the left hand, right hand, ankle, elbow, suprapubic region. They did not have an erythematous base, so they were kind of had a non-inflammatory background. They were somewhat fluctuant and fragile, so we were able to unroof them easily with a blade. And when this was done, a yellow-green serous fluid was removed. We also saw some scattered pink-white papules on the bilateral cheeks. So, any thoughts on the diagnosis? This was kind of what we were thinking in our differential. D. Excellent. That is a very good first step. But all that glitters is not gold, or whatever that means. So we did think it was C, and so in order to confirm and for academic reasons and since we are in a teaching institution, we thought it would be neat to send the contents of the blister to the lab and perform a right stain, which allows us to identify different inflammatory cells in the blood. So in C, what do we normally see a majority of? In C? Neutrophils, exactly. So we were really surprised when we looked at this under the microscope, because there were a number of sort of background neutrophils, which we would expect to see in transient neonatal pustular melanosis, but we also saw a ton of eosinophils. And we were kind of surprised by this finding, given the clinical presentation. So it got me to thinking, what exactly are these pustular diseases? And really, the thought right now is that transient neonatal pustular melanosis and erythema toxicum neonatorum are on a spectrum of disease as opposed to discrete disease entities. So normally we would expect to see an abundance of eosinophils in erythema toxicum neonatorum and an abundance of neutrophils in transient neonatal pustular melanosis. So the clinical really was matching more of TNPM, while the lab finding was an ETN finding. Here are some pertinent differences between these two diseases. ETN normally presents 24 to 48 hours after birth. Usually you see papules and pustules on an erythematous base, and they're classically filled with eosinophils. There are no clear conclusions as to what causes this inflammatory response, but it's thought that it might be to some sort of microbial colonization of the follicle in the first days of life. And luckily, this is a self-resolving process and no treatment is necessary. In contrast, transient neonatal pustular melanosis usually is present at birth. The vesicles are often filled with neutrophils, and there may be scattered, rare, less frequent eosinophils. And these often, again, are self-resolving, but they do heal with brown pigmented macules, and again, no treatment is necessary. And here's a Bologna image that contrasts the clinical findings. You can see that ETN does have a more erythematous background, while the transient neonatal pustular melanosis does not. So our case had some unusual findings. So there were vesicular pustules present at birth. They were on a non-erythematous base. They did disappear with brownish hyperpigmentation and a peripheral colorative scale. And then surprisingly, our right stain showed abundant eos and neutrophils. So what if the smear shows these findings and the clinical history is not quite right? There was actually a separate category introduced back in 1992, but by Ferrandis et al. To classify these presentations. They called this sterile transient neonatal pustulosis. This was based on an examination of about 3,500 babies, where of these 3,500 babies, they found that 17 had a sterile vesiculopustular eruption, and they biopsied 9 of these patients and found really mixed histopath evidence, where 2 of them showed intracorneal pustule with neutrophils, 5 showed an eosinophilic pustule, and surprisingly 2 showed both patterns, even though clinically these patients were all presenting as transient neonatal pustular melanosis. And perhaps most surprisingly, they saw different histopath findings in the same clinical lesion. So they biopsied lesions that looked identical, and yet one showed a majority of eosinophils and the other showed a neutrophilic pustule. There are a number of case reports in the literature that use this new disease name of sterile transient neonatal pustulosis. Here we see a 39-week-old baby that presented with these large flaccid pustules. So this picture here is day 4 of life, and you can see a close-up of those lesions. And they did perform a right stain, and again, clinically, this looked more like transient neonatal pustular melanosis, but on the right stain, there was a majority of eosinophils. These also resolved without pigmentation after about 2 weeks. And there's a second case out there as well that looked like a vesiculopustular eruption again. This one, I would argue, does have more of an erythematous background. But clinically, it did present at birth as opposed to 24 to 48 hours afterwards, so they were concerned that this might be a TNMP presentation, and they did a biopsy, and here again we saw or they saw predominantly eosinophilic pustule. So the conclusion then based on this case is that if you have a neonate who has a pustular eruption with mixed clinical presentation and lab findings, it doesn't necessarily have to fall into either TNMP or ETN, but maybe an overlap diagnosis. In terms of the differential, ruling out infectious etiology is the most important because that would necessitate a different therapy approach. But overall, the observations are reassuring as all three, TNMP, ETN, and sterile transient neonatal pustular melanosis, self-resolve and require no further treatment. Thank you, Dr. Johnson and the Stat Lab for performing this stain in like 20 minutes. They were really generous with their lab expertise. Thank you.
Thank you, Margaret. Just as a reminder, when you talk today, please hold the microphone close to your lips so the people at home can hear, and then wait to ask the question until you have the microphone. Also, welcome to all the applicants. I hope you had a good time last night. You came on a good weekend. I think Snowbird got 7 inches last night, so hopefully you can stay and enjoy it. Up next is Jenny Clark, I believe talking about ANA and Q&A.
Yes, that's right. I'm going to try and see if I can use this. I'll hook this on. Maybe. I'll set it here and then. All right. Is it close enough? Can you hear? Am I loud? Okay. If that changes, thumbs down. So thanks very much for coming. For those of you that braved the bad weather, thanks for all of you who went to great efforts, you resident applicants, to get here. We appreciate that so much. It's been a real pleasure to get to meet those of you who interviewed yesterday, and I'm excited to meet those of you interviewing today. I'm Jenny Clark. I'm one of our faculty members. And I am going to start out by finding my slides. That's not my talk. It is. Good, thanks, guys. All right, that looks like what I want to talk about. So conflict of interest, I'm supposed to tell you that my husband works for a molecular genetics company called Myriad Genetics that does molecular genetic testing. They don't do any testing related to ANAs or rheumatologic diagnoses, so this really is not a relevant disclosure. I do have one very relevant disclosure, however, to make, which is that I am employed by the best dermatology department in the universe. And we have the best dermatology residency in existence. So I have a conflict, and now you know my bias. I'm going to start this morning the ANA Q&A with a question for the resident applicant. So if you weren't nervous enough already, you're going to have to answer the first question. Which of the following is true of the residency at the in dermatology at the U? We have the highest wellness scores of all residents at the institution. We have a 100% pass rate on the ABD certification exam. We have a faculty to resident ratio of more than 4 to 1. The residency is comprised of bright, talented, fun, and enthusiastic residents who are encouraged to identify their professional passions and pursue them, or all of the above. Again, my biases are evident, but this is true. So. But we will talk about ANAs and do some Q&A, and I am going to begin this by asking all of you to answer some questions. So please raise your hands if you have had a patient with an ANA. Right, everybody. Okay. How about if you've had a patient ask for ANA testing, come in and tell you they want ANA, they're demanding this. How about, have you had a time when you have looked at the chief complaint before going into the room and it says ANA positive and rash, and you've seen this and you've started to sweat a little? Right? I think that happens. It makes us nervous. This is complicated, and we know on the other side of the door there's somebody very anxious probably as well. Who's actually ordered ANA testing? Right? Almost everybody in the room. Who's ever ordered ANA testing and then not been sure what to do with the result? Kind of wished you hadn't maybe ordered ANA testing afterwards. Who has kind of wondered which of these ANA tests that pop up in our drop-down menu should we actually order when a whole bunch show up? Or who have known exactly which test they wanted to order, but then they got on Epic or their EMR and haven't been able to find the darn test that they wanted to order, right? So I think these are common problems that all of us face from time to time. And I think what all of these hands being raised in the room show us is ANA tests are being ordered all of the time. I don't know the exact numbers right now, but ARUP laboratories, in a paper written, it's now almost 10 years old, they were performing, that's our local lab, 12,000 ANA tests per month. Now that's not just from our hospital. This is a large reference lab where patient samples are being sent in from across the country, but 12,000 a month. This test is being ordered a lot, and that was 10 years ago. So it's important for us, I think, to understand what ANAs are. So we're all speaking the same language and understanding what it is we're looking for, and then being able to really choose appropriately which patients that come into dermatology clinics that we're screening for rheumatologic disease with ANA tests. Knowing how to order them, what ANA tests to order, and how to find them in your EMR is really important. We'll talk about that specifically for our EMR today anyhow, and then how to interpret those results. So, what are ANAs? What do we mean? ANA is really an umbrella term. ANA is not a single autoantibody. Rather, it's really a group of different autoantibodies, all targeting different autoantigens. So not one antibody, but a whole group of different antibodies. The antigenic targets of ANAs are molecules that can be found within the nucleus, within nucleoli, in the nuclear envelope, but also in the cytoplasm. So this name ANA is a little bit confusing, but really when we're talking about ANAs, we are talking about rather what might better be known as autoantibodies to intracellular antigens. That name's not going to catch on. They're still going to be called ANAs. But we're talking about a broad group of antibodies, not confined just to those in the nucleus. And within each of these cellular compartments, there are specific molecules that are the targets of these autoantibodies that you can test for in a patient that you've found to have ANA positivity. You know they might have one of these. Now these individual disease-specific autoantibodies are sometimes referred to as ENAs. This is, strictly speaking, ENAs actually are kind of a small group of antigens that are extractable from in saline from nuclear substrates. But the term has broadly been used to describe all of these, this whole group of these specific autoantibodies. So that's what people mean when they say, well, what ENA does the patient have? These might better be referred to as antibodies to intracellular specific antigens, but again, that's not going to pick up a whole lot of traction. So they're called ENAs. So how do we detect these? There are lots of different tests for detecting ANAs, but in clinical practice, the two most commonly used tests, and the ones that we have the option to order here and at most institutions, are either immunofluorescent antibody testing on a HEP2 or human epithelial cell substrate, so this is called the IFA test, or ELISA testing. ANA detection by IFA on HEP2 cells. This is performed by collecting the patient's blood, taking that serum and serially diluting the serum, and then applying it to a microscope slide to which are affixed these HEP2 cells. And if a patient has ANA antibodies, they are going to bind to these HEP2 cells. And then we wash away any unbound antibody. And we then apply a second antibody. This one is an anti-IgG antibody that's fluorescently labeled, and it's going to bind to the patient's ANAs that are bound to those HEP2 cells. And the fluorescence pattern can then be examined under the microscope by a technician who looks at it and can tell us whether they see fluorescence and at what dilution of the patient's serum, they're seeing the fluorescence last appear and then disappear. So when they look under the microscope, they can see all these beautiful patterns. So an ANA by IFA test is reported with a titer, and the titer refers to the smallest serum dilution, the patient's serum, at which you can see fluorescence under the microscope, the lowest dilution. So that's the titer portion. And then we also get a pattern reported, which reflects the fluorescence, the pattern of fluorescence, where the technician is able to actually see fluorescence under the microscope. It may be in the nuclei, it may be in the cytoplasm, it may be both, it may only be in mitotically active cells. And then they even subdivide these patterns further based on what that fluorescence looks like. So you can imagine this requires some technical expertise to do, but you get a report with a titer and a pattern of fluorescence. The other test is the ELISA test that we can order. This has a kit where you get this little chamber containing a bunch of microwells, and the microwells have not cells attached to the wells, but actual antigens that ANAs may target. So in each well, and we take dilutions of patient serum and pour them into the wells, and it have ANA antibodies to those antigens in each particular cell or any of the cells or wells. They'll bind, and then in the next step, that anti-IgG antibody is added to the wells. It will bind to any patient serum ANA that's stuck to the wells now, and that IgG has an enzyme linked to it that will catalyze a reaction in the third step that'll create a color change indicating the presence of that antibody. And that color change can then be read on a colorimeter to determine whether the antibody is there or not. And in some cases, based on how much color is detected, it indicates how much antibody is there. So the report from an ELISA, in some cases, is qualitative, just ANA is present or absent. And in some ELISAs, you will get a numeric value kind of reflecting how much color change there was, which correlates with how much antibody is present. So those are our two tests that we can order for looking at an ANA. Well, why are we looking for ANAs? Clearly, we're all doing it, right? Well, that's because, of course, they're associated with diseases, and their presence can support a clinical diagnostic suspicion of a rheumatic skin disease. And they can be a portion of the actual diagnostic criteria of these diseases. And the ones we're usually looking for are lupus or drug-induced lupus, in dermatology, systemic sclerosis, and dermatomyositis. So it's an important test, and it helps us find out whether a patient may have a potentially serious condition. Why did we groan about sometimes ordering ANAs? ANAs have a lot of problems, or detecting ANAs, of course, can be kind of problematic as well. And the biggest problem is that ANAs are more common than the diseases that they are associated with. So ANAs in the general population, if you look at screening just anybody, not selected patients, but the general population with that IFA on HEP2 cells, you'll find that up to 30% of people can be detected to have a very low titer ANA of 1 to 40. 1 in 3 people is walking around who could potentially be told they have a positive ANA test. As that titer changes and we see that the dilutions change to allow us to see the positive ANA, we get down to about a level of a titer of 1 to 160. About 5% of otherwise healthy people will have an ANA with a titer of 1 to 160, and this is generally sort of the cutoff or threshold at which we think of an ANA being significant, maybe being associated with an autoimmune disease. But 5% of the population has that. That's 1 in 20. Doesn't sound like maybe much, but it's kind of a lot when you actually compare it to how prevalent something like lupus is, where you're seeing 20 to 150 people per 100,000 who have that. Relative to 1 in 5 who are still going to have a significant ANA titer. So an important take-home point is that the most common reason in an unselected population for a positive ANA test is nothing. It's to be normal. And this is important to try and convey to patients. When a patient is diagnosed as having an ANA, they go online and they immediately think that they're going to have all of the rheumatologic diseases that pop up, whereas the greatest likelihood, even with a significant titer, is that they don't have any problem. Important to note, too, about ANAs is, should we be rechecking them over time? Should we be following them? And really the answer is no. A patient that has a negative ANA has only about a 1% chance of that ever changing in the course of their lifetimes. So unless they have a major and significant change in health, checking another ANA in the future is not a necessary thing to do. And the other reason not to check them is that the titers really don't correlate in any way with disease activity. So you can't use them to predict a flare of a disease, and you can't use them to monitor response to treatment. So you don't need to keep checking ANAs over and over again. Another problem with ANAs is an ANA is not really diagnostic of any one condition at all, right? So we see them in rheumatologic diseases, but we see them in an awful lot of non-rheumatologic diseases in a greater number than we see in normal people. So they can occur in inflammatory diseases, they can occur in non-rheumatologic autoimmune diseases. We can see them sometimes in the setting of infection and malignancy, and there are drugs that can trigger ANAs. So having an ANA doesn't mean that you have rheumatologic disease. And the third is Sontheimer's corollary to Greenwald's law of lupus. This is a shout out to Rick Sontheimer, who is almost always watching from home. So hi, Rick. Rick is one of our faculty members, and he is one of the greatest contributors to our understanding of cutaneous lupus in the field of medicine. So we're really lucky to have Rick here. And what this is, Greenwald's law of lupus is a law that states that once someone's been diagnosed with lupus, everything that happens to them subsequently is attributed to lupus, whether it really is or not, health-wise. And Sontheimer's corollary to this is once someone's been diagnosed with a positive ANA, anything that happens to them subsequently is blamed back on that positive ANA. So once that seed is planted in a patient's mind or a physician's mind, it's really hard to kind of shake this idea that they probably have some underlying rheumatologic disease. And it leads to undue anxiety, undue testing, and there are studies that have shown that patients with a positive ANA, even in the absence of any diagnosis, are really actually have a great likelihood of being treated with high doses of systemic corticosteroids for anything that they complain about. So undue treatment in these patients as well. So there are some problems with the test. We have a lot of anxiety. Who should we actually be testing in dermatology with ANA testing? Let's look at a case. Think about this for a minute. This is a man in his 40s. Comes into clinic with a 5-year history of flushing, persistent diffuse facial erythema that is associated with a stinging and burning sensation. His past medical history is significant just for mild hypertension. When you do a review of symptoms, he says, yeah, I've got a lot of low back pain, and I am very fatigued. So do you order an ANA? You don't have to answer now, but think about it. Luke's given me the thumb just down, but you can still hear me, right? Okay. Okay. So the dermatology patients that should have ANA testing, what I would propose is we should only do ANA testing in our patients that have signs, symptoms, and/or history that is really suggestive of a specific rheumatic skin disease like cutaneous lupus, dermatomyositis, or scleroderma. Breaking this down a little bit more, that would mean patients with photosensitivity, particularly photosensitivity you're actually observing, that you don't have a drug trigger for. That might be an indication in dermatology clinic to do an ANA test. Patients who have Raynaud's phenomenon in association with other symptoms like sclerodactyly or GERD or calcinosis and telangiectasia, which you'd see in limited cutaneous systemic sclerosis or CREST syndrome, so Raynaud's with other symptoms or findings, or very significant sicca symptoms. So not the little bit of dry mouth I'm getting talking up here, or dry eyes that so many patients complain about, but rather patients who really have significant dry eye, dry mouth, and you're worried about Sjogren's. that would be another time to consider doing an ANA test in our dermatology patients. Who should not in our clinics be getting ANA tests? Well, patients who don't have those signs, symptoms, and history suggestive of a very specific rheumatologic diagnosis. Fatigue is one of those common ones that people end up getting an ANA for. Fatigue is not a specific finding. And rash plus fatigue, if that rash does not look rheumatologic in nature, should not warrant an ANA test, nor should just generalized pain. Hair loss, urticaria, pernio, Raynaud's, in isolation, none of these findings or symptoms warrants an ANA test. They can occur more frequently in patients with rheumatologic disease, but if the patient has nothing else except for these problems, this is not the time to order an ANA test. Who should have ANA testing? Let's go back and look at our patient. So, should you have ANA testing? I see nose, see some, mainly nose, right? So, no. This gentleman has rosacea. But if you weren't sure, if you thought maybe this is photosensitivity, and we see a lot of patients with photosensitivity, rosacea can flare with sun exposure, and they may have some vague constitutional symptoms. If you're not sure, the best test to do is a skin biopsy. Because the skin biopsy is going to look really different in rosacea than it is in cutaneous lupus. And from there, get your answer, rather than ordering an ANA and opening Pandora's box. So, if I haven't beaten this horse dead enough, don't order ANA testing in the absence of a high index of suspicion of a specific rheumatologic disease. So, I mentioned these two different tests that you can order to look for an ANA. Which of them should we be ordering? That ANA test by IFA on the HEP2, remember they got to look at it under the microscope, so this requires the skill of a technician, and you hope that the skill is the same with every technician in the lab, so they're reporting things all the same. This is going to take a lot of time, and skill plus time equals money. So this is a more expensive test, but it does give you a lot of information. In contrast, the ELISA doesn't require quite as much skill. It's fully automated. It's high throughput. You can do lots of them at once. It doesn't take very much time relative to the IFA test, and hence not quite as expensive. So kind of at first seems like a no-brainer, but these tests also have some other pitfalls to know about. In the ELISA, remember we've got specific antigens coding this group of wells. We have a finite number of wells here, so we have a finite number of antigens that we're testing. And it turns out there are hundreds of different ANA antibodies and corresponding molecular antigenic targets. So if your ANA doesn't happen to be in this kit, your patient's going to have a negative result. So the ELISA test can end up having more false negatives than the IFA test. And in some cases, the plastic that these wells are made of can denature double-stranded DNA to single-stranded DNA, and you may end up with false positives that really are not significant because of this. The IFA on HEP2 cells, generally very sensitive. However, these HEP2 cells poorly express a couple really important antigenic targets, which include Rho or SSA, which we see in so many of our cutaneous lupus patients, and then the anti-synthetase antibodies and MDA5, some of our dermatomyositis-specific antibodies. So they may pick them up, but they don't express these antigens as well as many of the others. So we might have some false negatives in patients who actually have these antibodies. And then we talked about the titer and how important it is to not react to a titer that's not at least 1 to 160, because we can get a lot of false positive results this way with this test. So all that said, the ANA detection by IFA is still considered the gold standard test for screening at this time. This is what's recommended by the American College of Rheumatology, again, in a patient that you have a high degree of clinical suspicion for a rheumatologic disease. I think over time that may change, because really the goal would be to have a fully automated, completely objective test that doesn't rely on observing fluorescence patterns. And so, it may be that later on in our careers, we're seeing different tests as our main screening. But for now, what I would recommend to you in dermatology clinic and a patient that you have a high suspicion for rheumatic skin disease, the screening test you should order would be the ANA by IFA. If you get a positive result on any kind of ANA testing, you aren't done there. You have to do some additional testing. Now, if a patient is tested, if you order that ELISA test, and it comes back positive, the lab reflexively confirms that with an IFA. So that's gonna happen if you do go ahead and order the ELISA for screening. When the IFA test comes back positive, again, we just know that this umbrella ANA is positive. So we have to go on then and check for those disease-specific antibodies as our next step. So some more testing will be necessary in these patients. And a negative ANA may still require some additional testing because, again, we're only looking for this in patients that we have a high degree of clinical suspicion for rheumatologic skin disease. Again, if it was an ELISA test that the patient comes in with, that they show you that it's negative, that test is complicated by some false negatives because they might have an antigen that wasn't picked up in that ELISA kit. So you're going to want to go ahead and order an ANA by IFA, even though they have a negative ELISA if you're really suspicious. If they have a negative ANA by IFA, remember, we're looking often for cutaneous lupus, and the Rho or SSA antibody is not always expressed highly by these HEP2 cells and may have been missed in the IFA test. So you want to order the SSA or Rho antibodies, or if you're worried about dermatomyositis, those cells also may have missed antibodies that are present, so ordering those specific antibodies. Let's do a couple of cases just to illustrate that. This is a patient that comes in with these depigmented, atrophic, scarred plaques with hyperpigmentation peripherally on her forehead, and a large patch of scarring alopecia that has erythematous, pink-red, scaly patches at the border and a depigmented center. So what does she have? Right, she's got discoid lupus. And she comes in and she says, well, here's my ANA test that my doctor ordered. It was negative. This was an ANA by ELISA. Are we done? We're worried that this patient has lupus. She's got discoid lupus. We want to do a little additional testing because this is a patient that does potentially have a risk of having systemic disease now or in the future. So here's an example where a negative ANA test requires some further testing, and you do want to order the ANA by IFA, and she, in fact, turned out to have a significant ANA titer of 1 to 640. This is a patient that came into resident clinic last month and was taken care of by the astute Dr. Kimberly Blaine. And she walked into the room and took a look at this man's rash and saw this very photo-distributed eruption where there were pink papules and patches, some of which were scaly, some of which had an annular configuration. And she thought, this kind of looks like subacute cutaneous lupus. And so she sat down and talked with him a little bit more, and he said, well, I did start a new medication, a proton pump inhibitor, about 2 months ago. She said, aha, I think this patient has drug-induced subacute cutaneous lupus. So she ordered the IFA test for the ANA, and it came back negative, the titer of 1 to 80. But did Dr. Blaine stop there? No. She went on, and because she had a high index of suspicion, ordered an SSA that was positive. So our IFA test can miss that Rho SSA antibody. So this patient had proton pump inhibitor-induced, drug-induced subacute cutaneous lupus. And then finally, this is a good job, Dr. Blaine. This patient comes in and has red patches that flare up on her neck and chest and face whenever she's in the sun. So she's got photosensitivity. She describes arthralgias, some fatigue. She has sicca symptoms that are significant. You review her chart, and she's got a mildly low white blood count. You're worried about potential lupus, and you get an IFA ANA test that's positive. Are you finished? No. you need to now find out more about her by ordering those disease-specific antigen tests, the ENAs. And so when a patient has an ANA titer of at least 1 to 160, and you have that index of suspicion, you want to order these tests as your next step. Okay. So this is my sort of general algorithm that I would recommend following for a patient with suspected rheumatic skin disease. You're going to order an ANA by IFA, and if you get a positive titer, 1 to 160 or greater, you go back and think about what condition that patient might have that prompted you to order the test in the first place, and you order disease-specific antibody tests. On the other hand, if you ordered that ANA by IFA and it came back with a negative result or a low titer, look back and think, did I think that this patient had dermatomyositis? Because I know the ANA by IFA might miss some of those patients and order dermatomyositis-specific testing. If you weren't really worried about dermatomyositis, you were probably worried about something like cutaneous lupus or maybe an overlap syndrome, so order the SSA-SSB. So, a lot of groans when we talked about how to find the test you want to find in EPIC. So now you know you want to order that IFA. You're in a busy clinic. You ask your medical assistant to put in an ANA, and she gives you a blank stare. And that is because EPIC is so helpful at finding these things. And she says, all right, what to do? What should I type in? And you say, type in ANA. Intuitively, that's what it seems like you ought to type in when you want the ANA test. Not so much. First of all, you get this list like this, most of which are testing for anal problems. But 2 of these are ANA-specific tests, the top 2. ANA reflex profile and ANA IgG ELISA. Both of these are the ELISA tests, not the ones I would recommend you use for your screening in a patient you're really suspicious of. So this doesn't get you anywhere. The secret to finding what you want in EPIC for the right ANA test is to type in the word anti-nuclear. The password is anti-nuclear. You have to use that whole word and type that in. And when you do that, you get this list, and about 2/3 of the way down comes up ANA, anti-nuclear antibody, HEP2 IgG. This is your ANA by IFA. This is the test that you want to order as your screening test. What about panels? There are all of these different lupus panels and interstitial lung disease panels and dermatomyositis. Can I just order one test that's going to tell me everything I want without having to go through all these steps? And in general, I'd say the answer is no. Most of the panels start with an ELISA, which can have a lot of false negatives, so you're not going to get the reflex testing to the specific antibodies by ordering panels. There is one anti-nuclear, again, you type in, that is the top one that shows up there in purple, anti-nuclear HEP2 IgG with reflex. So this would be one that you could consider. It effectively does an ANA by IFA with then reflexive testing for antibodies specific to lupus or scleroderma or mixed connective tissue disease or overlap syndromes based on the pattern of fluorescence seen in that initial IFA. But we know a lot of the patients we're looking at in dermatology might have SSA antibodies or might have dermatomyositis and aren't going to be picked up by this test. So I still think the very best thing is just to start with that ANA by IFA, think about what it is you're looking for, and then order subsequent testing. The one panel I do like is the dermatomyositis testing panel. If you have a patient you think might have dermatomyositis, and this one's not really intuitive either, because you type in dermatomyositis and 2 panels pop up. Dermatomyositis panel seems like what we would want. I recommend ordering the dermatomyositis and polymyositis panel. And that's because this panel will include antisynthetase antibodies in addition to the dermatomyositis-specific antibodies, which are the MDA5, TIF1, SAE, NXP2, and MI2. So this panel will give you a more full appreciation of what your dermatomyositis patients could have. I recommend going to the ARUP website if you want to kind of learn more about what your test options are. It's really, really helpful. You can go through all of these different panels, learn about what they offer, what's going to be tested. I've learned a lot by looking at it, so I think it's a really helpful website. But I caution you, there are a lot of panels out there that you can be ordering. So just kind of knowing these few tests, I think, is really the easier way to start. So to sum up, don't order an ANA test in the absence of a high index of clinical suspicion. And consider your patient and the clinical context and the ANA pitfalls to determine what you're going to do next. Remember, we're going to start with IFA testing, but it can be positive in a lot of healthy people. It can be positive in patients who don't have rheumatologic skin disease. And it may also miss a couple of important autoantibodies in our patients with cutaneous lupus and dermatomyositis. So subsequent SSA testing or dermatomyositis-specific antibody testing may be needed. And when you're working in EPIC, the key is to type anti-nuclear, not ANA, to find the IFA test, if you're using EPIC here anyhow. And the panel to use for your dermatomyositis patients is the dermatomyositis and polymyositis panel. So with that, I will end and turn ANA Q&A over to you and take your questions. Doug.
Sorry, can I ask one quick question before we get the microphone up?
You're getting scooped, Doug.
Sorry, Doug. So when you have a patient who comes in asking for you to test them for ANA and your clinical suspicion is very low, how do you approach them?
I just say no and walk out of the room. No, I mean, I think you have to have the conversation and explain try and explain to some degree the complexities of this test and the fact that we often will find positive results that really are not meaningful, and that unless they have other symptoms that would really affect how we would treat them or prompt us to make another diagnosis, even a positive test result at this point isn't going to affect their management.
That was an excellent talk. I have two questions. One, in your management algorithm, you didn't really address the role of biopsy. And so my question is, if you have strong clinical suspicion, you perform a biopsy, and that's essentially diagnostic, how is the ANA then relevant? Like in your first two cases, rather than first ordering the ANA, if you had performed the biopsy and that was diagnostic for DLE fitting with the clinical presentation, then would you even order the test? Because if you have a strong clinical suspicion and biopsy confirming, would a negative ANA cause you to change your diagnosis? Probably not, right? Or no?
Yeah, I agree with you. And in fact, with that first patient with discoid lupus, you might not even perform biopsy. Sometimes these patients are so clinically obvious, you don't need to do that. So I didn't include things like biopsy. There are a lot of other blood tests. In your dermatomyositis patients, you're also going to be ordering muscle enzymes and things like that. But in a patient that has discoid lupus or cutaneous lupus or dermatomyositis, knowing about their disease-specific autoantibodies can help you with prognosis and better kind of fine-tune their diagnosis. So I still think you're going to go on and order those tests, but you're right, to actually make the diagnosis, they're not necessary.
In terms of cost, how's an ANA compared to cost of a biopsy?
A biopsy is more expensive than an ANA, but you're getting different information from both of those. So I think they're both very important parts of the work.
Final question: do you think that they should revise the way that these the results are reported, given that it sounds like less than a 1 to 100 or something you consider not clinically significant? Whether they should, I mean, it seems like that an obvious thing to do would maybe just start out with a 1 to 10 or 1 to 7 dilution and then report or something. But it seemed like this has been going on for so many years and no one's thought of that.
Yeah, and I think that there has been some change. It used to be, I think, routinely 1 to 40 was reported in most labs as positive, and now here anything less than 1 to 80 is considered negative, and once you get to 1 to 160, you get a positive, or 1 to 80 or greater, you get a positive result. There's a lot of variability between even the kits used for the IFA from lab to lab, so a titer at one lab may be different than a titer at another. So that's why I think ultimately having these more sort of solid state assays that don't require this kind of technical expertise and individual variability are going to be the answer down the road.
Hi, Jenny. It's Christina.
Hi, Christina.
That was excellent. I just wanted to suggest that that DER panel, that DER dermatomyositis panel, is actually an institutional panel that was created for us. And if we don't like it, we can fix it. And we could create some panels that help us find them, and we could even name them ANA if that makes it easier for our trainees and everyone.
Christina, that would be wonderful. Christina is our epic, super duper user, and that would be helpful. Because I think it's really frustrating when you're in clinic and you can't find it and your MAs can't find it.
So do anti-nuclear antibodies cause disease?
So anti-nuclear antibodies are associated with disease. They're not, as far as we know, generally directly pathogenic, which is, again, the titers don't correlate with disease activity. So they're associated with disease, but exactly the way in which they are involved in the autoimmune response is still not fully well understood.
Yeah, it's always been somewhat mysterious because the party line, of course, is that IgG does not cross cell surfaces. So whether in vivo it does anything to living cells is debatable.
Right.
Whereas its effect is probably all related to dead cells.
Apoptotic cells and subsequent inflammation, yeah. Thank you.
Okay. Thank you again, Jenny, for that wonderful presentation. We're going to start with our patient presentations. So starting in room, I'll call it 1. Grace, do you mind giving us a description?
I would love to. So this was a 57-year-old gentleman who has been experiencing pretty significant nail dystrophy for about a year. So to just describe these lesions here, on the feet, we can see that digits 1 through 3 on both feet are affected with this kind of brown, yellow, maybe yellow tan discoloration. It's hyperkeratotic. There's even some what I would describe as onycholysis. No pitting, but there is longitudinal ridging. And then on the hands here, you can see that all 5 digits on both hands are affected. And again, no pitting, just that thickening, that yellow tan discoloration. There is some onycholysis. On the thumbs, though, it's more just a lifting of the entire, excuse me, the entire nail bed. And that is how I would describe it.
Sorry, did you say about his toes? Are they all affected or some?
So the toes, no, the toes just 1 through 3 on both feet are affected. Digits 1 through 3, 4 and 5 do seem to be spared. And the toes specifically, I felt like the digits 2 and 3 had some onycholysis, but the helices there more just kind of thickening. And then you do see that ridging there as well.
Any erythema or anything in the interdigital web spaces?
No erythema, no scaling, or like patches or plaques or anything really associated with the skin itself. It seemed to be really limited to the nails specifically.
Joint changes?
No joint changes, no joint pain, no swelling, no edema, no pain that he endorsed.
You want to start a differential?
Yeah, absolutely. Things I would think of with this, of course, would be like a fungal infection. Think about like trachyonychia. Think about think about psoriasis with the nail involvement, but it's probably lower on the differential.
Second years, anything you want to add to the differential?
Could add lichen planus. Thought about pachyonychia congenita. Timeline wouldn't really fit. PRP can have similar nail changes, but other findings.
Fearless Chiefs.
Candidiasis, alopecia areata, eczema, atopic disease can cause the trichonychia as well.
I think we have some Pat. Pseudomonas from Pat. Anything else people would add to the differential in the audience? Nutritional deficiencies from Luke.
Yellow nail syndrome. Interstitial lung disease and lymphedema, but apparently that triad never really happens. Sometimes it does. So I have the pathology. We have 2 nail clippings. This was the first one done about, I don't know, maybe like 6 months ago or a little bit longer. And on low power, it's really just shows, thickened nail plate. There's nothing really remarkable about it. There are actually some areas, just sort of add to a little bit more of the histologic descriptions. There were areas of these lakes of blood, and there was a little bit of perikeratosis that was seen in the nail clipping, but perikeratosis can be like a normal nail finding. And this one was reported out as showing some microorganisms that was listed as yeast or spores, and this is the PAS showing these elements. We have another one that was done most recently this year, and this one is even more unremarkable and actually doesn't have those elements that I mentioned earlier with the lakes of blood, or the perikeratosis isn't as prominent, and microorganisms were not seen on this one. Oh yes, they were sent for culture. The first one was, and I forget what it was, grew out. Does any of the first years know?
Luke, we'll bring a microphone up to you. Hang tight. Keep hanging.
Even the people at home can hear me. So this is my patient. The first time I clipped his nails about 7 or 8 months ago, the culture was negative, and the histo showed a bunch of yeast. Put him on terbinafine for 3 months. We actually presented him for grand rounds after that course, about just virtually. And the consensus seemed to be try a different antifungal and maybe check his iron levels, because he looked like he had some koilonychia. So put him on pulse dose itraconazole for 3 months, and then his nails weren't any better. So I did another clipping for histo and culture, and this time the histo showed nothing, but the culture is growing Aspergillus niger and penicillium species. His iron levels were fine.
So
try putting some, you might try one nail and just get the ophthalmic gentamicin and try it. I've seen it work. Up night. Yeah, I mean, it's going to take at least 6 months for a nail. I mean, probably a year for a big toenail, but this, you might see some improvement. It just seems a little odd that it's all his nails, though. I mean, I think if it's Pseudomonas, it probably would have just been 1 or 2, not all. Yeah, maybe.
I'd just like to. So
make the comment that we've got a lot to learn yet, because this guy also has pincer nails, and it happens that they're both on the third digit. And then the lateral toenails are negative. In my experience, the lateral toenails are frequently negative, but the other ones are not. They have some pathology. These guys, his third toes do, and his big toes do. I have a heck of a time trying to make an infectious disease out of that. And so there's got to be some mechanical force or some other thing that's going on that needs to be defined.
I agree, and I wouldn't totally rule out psoriasis. I agree with you, Jerry. I think there could be, two things going on. So probably 30% of people with psoriatic nail disease also grow out various fungal elements. So I think that if you don't get anywhere with the infectious disease workup, you could consider a course of a biologic for 6 months, just to, empirically see if it improves, a TNF agent or something like that, as long as he doesn't have any other underlying reason. So if somebody has koilonychia and iron deficiency, you may want to go hunting for an underlying malignancy. The diagnosis into EPIC. Yeah, no, you could diagnose possible psoriatic nails. I mean, there's enough features there that you could say it's consistent with that, and you can usually get that approved. So, we also have samples. So I've done this a number of times, make a deal with the insurance company, say, let me do this for 6 or 9 months. So.
Old.
So I have two questions about that. One is, it sounds like you would do that without getting a nail matrix biopsy. And the other is, which biologic is best?
Do I have to announce my conflicts of interest first? So most of the biologics now have pretty good nail data. So any of the classes is probably going to be okay. I would generally start with the TNF agent because there's more data, and there really hasn't been any superiority of the other classes over that for nail disease. So I think adalimumab has probably the best data there. I don't know, would that help you guys do you feel like if it was negative, would it completely rule out psoriasis, right? So it's kind of I guess that's sort of the question. Yeah, you certainly do that.
I don't see them that often. Sorry. So unless you had subcorneal pustules that you'd say, and it's sterile, that that would support psoriasis, but you may just get a pretty nonspecific thing, and it's going to be a big deal to do that biopsy.
I would vote actually to do a biopsy if you get to that stage before you do, systemic biologic, because then you get the nail off, you could sample the entire nail, so you could do a culture and a PAS on a more than a clipping. Sensitivity of clippings is very low, at least that I've found in my practice. Clinically, I think this is onychomycosis. So if it's psoriasis, they still have onychomycosis, and you're going to have to treat that part of it. And I'd probably do pulse fluconazole for 6 months or longer. The reasons the other nails aren't involved yet is because they're not infected yet. But I bet those other nails will eventually start showing the same thing. But it's going to take forever. Aspergillus is notoriously very hard to treat, but it is a non-dermatophyte mold that can infect the nail. But this may be a situation where avulsing a whole nail, sampling the whole nail, and then do a matrical biopsy would help you in your treatment planning.
And Chris would love to do that for you. Any topical approaches, recommendations? Nothing. Anything else, Luke? Don't get an ANA from Dr. Clark. All right, we'll move on to the next room. Chloe, let's have you describe.
Sure. So we have a 17-year-old who has had a depression in her right buttocks since this summer, May, or spring. On exam, the lesion is soft, atrophic plaque with kind of lilac violaceous hue to the central portion, and healed biopsy scar. That's because it could be interpreted as like an erosion ulceration, but that's where the biopsy was. And that's it. She doesn't have any other lesions. It's non-tender to palpation. And I don't know if other people got this history, but her mother had an atrophic lesion on her buttocks as well, but hers has resolved, and they believe that was from a steroid injection that she had there.
You want to start a differential?
For the mother?
That was on the mother.
Yeah.
This patient has not had any steroid injections or topical, I believe.
So top of the differential for her is morphia. It's also lipoatrophy, paniculitis, trauma. What I've got.
Yeah, and the patient denied any like bug bite or trauma or anything to this area. Second year, is anything you want to add to the differential?
I would say atypical, but maybe lichen sclerosis if we're considering morphia.
All right. So we received So we received a punch biopsy from an outside institution, and we reviewed it. And as you can see from low-powered, there is a relatively squared biopsy that goes pretty deep down into the fat. So there's a little tail end of fat at the bottom right there. And overall, you can see this remarkable expanded eosinophilic collagen with decreased spaces in between. And even at low power, you don't really appreciate any sort of expanded cellular population or mucin deposition or anything like that. On closer magnification, you can just appreciate that a little bit more. And what I want to highlight that I think is a pretty good finding for this entity is those eccrine glands. So as you can see it right there, they look like they're deep, right? But actually, they're a little bit higher than where they should be, because they should be sitting down near where the dermis and adipose layers are meeting, but actually it's raised up a little bit. And additionally, around it, normal eccrine glands have a healthy amount of fat to help with all their energy needs and whatnot. So this was read out by an intermountain pathologist as dermal sclerosis favoring morphia, and I would actually say it's pretty dang good for morphia with all its features. And I was talking to Scott about this yesterday, and I was mentioning the eccrine coils because I think I remember there being an ASDP Pearl lecture that I was at about someone talking to this. I was like, I know there is a study, and I couldn't get it because it was behind the American Journal of Dermatopathology's firewall, which is massive and very difficult to get any journal article from. But I did have the lovely Dr. Margaret Cox, who actually ended up presenting this like several years ago or last year. And this is the study that she went over, and it's the line sign. And so they basically looked at histologic features in morphia. And they were specifically talking about the line sign, which is, and this is courtesy of Dr. Cox and her beautiful slides, this is specifically the line sign, which is where there is this nice line between the junction of the adipose and dermis. And you can see that fairly readily in morphia, whereas you shouldn't have such a straight line in normal skin. And one of the things that actually became the most sensitive feature of morphia was those eccrine glands. So they looked at the highly displaced and lacking adipose tissue around the eccrine coils, and that in itself was probably the best feature for finding morphia. And they looked at some other things as well among these cases. That's all I have to say. Good for morphia.
So this was an outside provider. Were they just wondering about treatment or what?
Lindsay Mitchell. Yeah, we think the provider is Lindsay Mitchell. No. I thought it was... Never mind. Way outside. We don't know him. She tried clobetasol and calcipotriene for a month using both BID, and apparently the lesion got bigger. And so when that was discussed at the second visit, she was referred for treatment options. Yeah.
Treatment recommendations. Coming.
I feel like I'm talking too much at this conference. So for kids with bad morphia, sometimes we'll do methotrexate, and the guidelines are to do it for 2 years. So whether this counts as bad morphia or not is probably a little bit subjective. So for kids who have like Ankudasab or something like that, then we do it. So you could at least discuss that with them. Sometimes people do ILK, though it's already atrophic, so that would be a little sketch. There's decent data behind phototherapy, and with such an isolated spot, you could potentially do excimer laser, see if you get improvement that way. She's always going to have this atrophy, so the goal is to get the ongoing disease process to stop, and then potentially, once it's burned out for a few years, if this bothers her, it could be surgically excised or something, I suppose. Sorry, one more thing. So especially in kids, sometimes if you have morphia, you can have genital LSNA as well. So she should have a genital exam because it can be asymptomatic. So somebody should look and make sure she doesn't have it.
I think what's hard is we only have one time point with this patient, and so when they say it's bigger, how much bigger? I would still probably try topicals, maybe trying it with occlusion. And then if you're going to do systemic therapy, it's very rare that I've done methotrexate without using steroids. When you think it's bad morphia, and this clearly is not rapidly progressive linear morphia that requires systemic treatment without an adequately failed topical regimen, or like Luke said, light therapy, which might be a little uncomfortable given the distribution in one lesion.
Luke, you mentioned possible surgical revision. I've actually had 2 of these that once they're completely burned out, we did essentially Scar FX with polylactic acid, and they did, we did basically Scar FX settings on a CO2 laser with polylactic acid, both one topically, one intralesionally, and had good results with the atrophy. So it may not be something that requires surgical excision. There may be some other options for the atrophy after she's done, but it needs to be completely, obviously, burned out and clinically controlled before you want to add any energy or manipulate it further.
All right, we're running out of time. Any last minute comments? All right, thank you, everyone.
That was like super smooth.
Oh, good.
You have my phone number? Yeah.
Okay, I will be at inpatient rounds at clinic, so hopefully there's nothing too major, but I'll be around. I also don't remember any general dermatology.
happy to do that.
No, it's fine.
No, I that's
definitely is. That's definitely right. I think I can just feel her. She's like,
I know.
she's like,
I know.